Good afternoon, everyone. Welcome to this Facebook Live. Again, my name is Sue Hinds and I'm Head of Services at Dementia Carers Count, and I'm delighted to be joined again for this carer clinic by Dr. Raja, practising elderly and dementia care specialist. Dr. Raja has joined me for two previous Facebook Lives, and both of those are available on our YouTube channel. So if you'd like to go and have a look at them at some point, then they're there for you, and please do see what's there. We're going to carry on where we left off from those last two Facebook Lives. So to do that, I'm just going to ask Dr. Raja, could you introduce yourself and give us perhaps a little brief summary of what we visited in those first two sessions with you?
Thanks. So it's wonderful to be again discussing a very important topic related to dementia. So I'm Raj. I'm a consultant psychiatrist based in Guildford. And in our first session, we talked about recognizing symptoms of dementia using FORGET as an acronym, so people can recognize the symptoms. And I'm sure that FORGET slide is available on our website and people could refresh their memories. In the second session, we talked about different types of dementias, how they present slightly differently, and therefore the kind of investigations and support the person who's being diagnosed with dementia and the carer who looks after will need during that journey of understanding what symptoms are and how it leads to a particular form of dementia as a diagnosis.
Okay, brilliant. And so this is the third session, so following on from some of those signs and symptoms and then the types of dementia and the processes for diagnosis. Today we're looking at sort of two treatment options once a diagnosis has been met. Please, anybody, if you'd like to, please put questions in the chat and we'll try to come to them, or any comments that you have, and we'll address those. Sometimes it's not easy to spot every comment or question at the time, but if we don't cover one that you've put in the chat, then we will go back and have a look at them afterwards. And if you want to message us anonymously, that's absolutely fine as well. We know some people don't like to put their names in the chat. One thing I will say about this session, and I think you'll agree, Dr. Raja, is we can't, in terms of treatment options and particularly medications, we can't comment on individual cases in this short 30-minute Facebook Live. One, because we haven't got the time, but B, it wouldn't be appropriate because the specifics of individual cases really needs to be addressed by the physician that the person with dementia is seeing. So we will be, I know we've had a couple of questions already about some medications, and our advice would be to go back and talk to your physician about those. That's right, isn't it, Dr. Raja?
Absolutely. And when we start talking about the specific medication, we'll find out that a lot of symptom management is what we're considering when we're using medications, and because symptoms are unique to an individual, therefore we wouldn't be able to make broad general sweeping statements about medications. We need to understand the person, their physical health, the environment before actually prescribing, and therefore we need to be very cautious about it.
Thank you. So this session is treatment options, and you've just mentioned around medications and also non-medication based treatment, which includes environment and support that the person receives. And those are the two primary things that we're going to talk about in this session, aren't they, Dr. Raja? So if we could go to medication based treatments first and have a bit of discussion about that.
Yeah, absolutely, Sue. So if we start by focusing on dementia specific treatments, there are two groups of drugs, and a lot of people here might be very familiar with the terms like Aricept or donepezil, galantamine, rivastigmine, those kind of medications. They are useful medications for treating someone with an Alzheimer's type of dementia, sometimes even in Lewy body type of dementia. What they essentially do is they increase a substance called acetylcholine in our brain, which is very important for us because it helps us to have some degree of sustained attention on the task that we are doing. So hopefully, if someone was to measure my acetylcholine in the brain now, it should be peaking because I'm trying to be having my attention undivided and focusing on doing this session. So that's what people with dementia benefit from, although they could be having some problems with other cognitive domains. If we were to try and increase their ability to be more attentive, then perhaps it will help them to be having less problems in other areas of cognition. So that's what most of those medications do. Very useful medication, but unfortunately, as all medications do, they do come with adverse effects. That's simply because acetylcholine is present in all parts of the body, not just in the brain. So sometimes it can slow down the heart, sometimes it can cause gastric irritation, sometimes it can cause cramps. Not very alarming side effects, but side effects that one should be aware of. But it's a very useful category of medication to be looked at. The second group of medication, well, I call this group, but there's just one medication, and it's called memantine, and some of you might again be familiar with it. It's a medication which prevents the brain cells from dying. So essentially, it keeps the neuronal pool or the brain cell pool healthy and going. And the idea is that if we were to try and preserve brain cells, then it would effect into better connection between the brain cells and better function as such. And again, a safer medication to use. An important thing to monitor would be for kidney functioning to be appropriate, because the dose is dependent on how good the kidneys are. So again, a safe medication. Those are the two groups of medications that we have currently for dementia. And again, it's a medication that we could offer to Alzheimer's type of dementia and in some instances in vascular and Lewy body type of dementia as well. Beyond that, we do have some exciting times ahead. We have a lot of anti-inflammatory medications that are coming in. They're just waiting for approval by NICE, which is the National Institute for Clinical Excellence. And once it's approved, then we should be able to offer it to people who meet the particular category or criteria for prescription. So that is something that's exciting. And I think we'll see more of that in the next 12, 24 months. As far as symptom treatments go, a lot of people with dementia will present with a varying degree of insomnia, loss of appetite, depression, psychotic type symptoms like seeing things or hearing voices, or even becoming agitated and aggressive. So all of those things will need very specific consideration of particular type of medications that can help the particular symptom. For example, maybe an antidepressant would be useful in people who are presenting with low mood. Maybe a medication to promote sleep would be very helpful in someone who has very difficult insomnia. But these would generally not be the first line treatment options. They have to take into account the age of the person, the environment that they are in, who is going to administer and monitor for some of the adverse consequences that could happen, and more importantly, the physical health and nutritional status of the person. So that's why we started the session by saying that we can't provide individual advice, because these medications are entirely dependent on the individual and their unique set of circumstances, and hence the need for appropriate dosing of this medication. I want to state this again very strongly, that medications aren't first line for symptomatic management, and we'll be talking a little bit more about what else could be done.
Brilliant, thank you, Raja, and that is going to bring us on to the next section really nicely. Just to say to listeners, there were a lot of terms of medications that Raja used there: donepezil, Aricept, memantine, and it really is a quick overview in 30 minutes. So this recording, the same as the other recordings, will be available on the YouTube, so you can replay back, listen to as many times as you want to if some of that information went too quickly for you. And also, Raja, as you said, there's exciting advancements, particularly around the anti-inflammatory medications, which will be coming out over the next year or two. And we will keep people up to date through our website, and hopefully we'll ask Raja to write us an article or something perhaps to put on that website as more information emerges through it. But one of the things you said, Raja, just at the end there, was that often these medications aren't the first line of treatment, that they are the second option, and that there is environmental changes and other support mechanisms which can really impact on the well-being and the cognitive skills of somebody who does have a dementia. So I wonder if we could move on to these non-medication based treatments, if that's okay.
Yes. So I think the first thing to look at would be the daily activities of the individual and what they do during the course of the day. and how is their sleep routine, because those are two things that we could actually make more meaningful interventions to assist the individual. So having activities scheduled during the course of the day, not for any extended length of time, because we also need to appreciate that people with dementia may not be able to be attentive to a task beyond 10-15 minutes. So it's very important to make sure that they have both physical and mental health activities spread during the course of the day. So it keeps their brain active, it keeps their body physically active, and therefore towards the end of the day, they will feel that um, general tiredness and exhaustion that all of us get as the day progresses, and that will facilitate them to have a better sleep routine as well. Uh, and people have always asked me, when we say mental health activities, should my father start doing Sudoku or crosswords, things like that? It's very important to understand that brain does struggle with new learning when the dementia sets in. Therefore, I would always say to people that if someone has already loved doing certain mental activities, it's better to continue doing it. But I wouldn't really want them to learn something new, because that can become a frustrating task for the brain itself. So we need to be aware of that. And as I said, in smaller chunks of 10 to 15 minutes, then something that they're familiar with, that's very useful. People also would have had a lot of hobbies and interests in arts that they might be finding it useful. So for people who've been always interested in reading books, all the books may become a problem. They could still read newspaper columns, magazines, so that becomes a very useful activity. People who are interested in listening to music, absolutely great. Music therapy is recognized itself as a form of managing some of the behavioral problems in dementia. But I had to share an anecdote in the sense that a patient who was referred to me from a care home um, was referred with agitation, obviously very challenging new environment in the first few days, which is why I think we are going to do a session on environment sooner. But when I went and spoke to this person, and this person had this amazing interest in jazz music and was used to listening jazz music during the course of the day. So all that we had to do was to make sure that some jazz records were available for the person to listen to, and that calmed the person down. So that's what we mean by specific therapy. It's not necessarily that they have to sit down for hours together and engage in certain activities, but making sure that whatever they're familiar with, they're able to continue with it, and to make it more enjoyable to them. I think that makes a whole new difference to them, and it keeps people generally calmer and active.
Yeah, and Dr. Raja, David has commented here that music plays an important part in communicating with his dad, and he finishes his comment by saying it's able to help relax him. And that goes back to something that you said earlier about puzzles and cognitive sort of stimulation exercises, and the difficulty with new learning. If you are going to provide something to someone that is new learning or causes them stress or anxiety, or they feel they're being drilled and under pressure to do something, then that's not going to be helpful, is it? Even if some of the evidence says that you should do cognitive stimulation, if the person is feeling that you're putting them under pressure, then it's not worth it. But as David said with the music, he uses it to help relax his father. And we all do far better when we have a sense of well-being, don't we? Well-being is such an important part of treatment.
Absolutely, and I think you would also find that people with dementia do generally like talking about some of their fond memories from past or very significant events that they have witnessed or been part of. And I think, again, the technical term might be reminiscence therapy, but it's more about trying to understand the life and times that they lived in, and what they could actually have some very meaningful and enjoyable conversations. Because at the end of the day, the whole point would be to try and give the person the ability to communicate some important things that they want to communicate about, but also try and make it a very pleasant and enjoyable conversation that they could have. So that would be the focus of all these kind of very specific therapies. So we've talked about how to schedule the day using a lot of different activities. And then the question is about how to help with night, and therefore having a regular nighttime routine would be a good place to start. And also trying to understand that sometimes when people with dementia do have this dead night, it's because it's not that they're not tired. It's just that their clock says that it's a different time to what we think as nighttime. So being aware of the fact that they could be disoriented time, and that's why they're waking up, and therefore trying to manage it in a very different way would be helpful too. So those would be some of the major ways of trying to help people with dementia to have a better day-night schedule and activity, and that would help. Another important thing that people with dementia would have to be aware of is nutrition and hydration. Um, uh, People generally forget to drink adequate amount of fluids during the course of the time, and sometimes making sure that someone's got a jug of water or whatever they would prefer to drink would be very helpful place to start. And it's very important in summer months because dehydration can lead to delirium, and delirium can make the dementia worse. So it's very important to try and make sure that people are hydrated, especially in summer months. It's equally important to try and understand nutrition from the perspective of the person with dementia, because although we might be having a set pattern of eating breakfast, lunch, and tea or dinner, that may not be how the person with dementia would want things to happen. Part of the problem being their inability to orient to time. So they may not actually feel that it's evening time and therefore they have to have their main meal, or it's breakfast time and they have to eat certain things. So it is very important to make sure that they are nutritionally adequate, but it would be very unhelpful if they were to be forced to having 2 or 3 courses as it would normally happen. So having bite-sized meals, having finger foods spread during the course of the day, having sandwiches, that kind of stuff that makes it easier for them to digest, easier for them to have, would be very helpful too.
Yeah, and on that, Raja, I think that also comes back to a point you made at the start, that actually short amounts of time on physical and mental activity is better than longer periods. And just sitting down for a meal time is quite a lot of cognitive demand on a person for 30 minutes of how does the brain work out how to eat and how to drink and how to swallow. So again, it's another reason for doing bite-sized, is the person may be disorientated to time, but they must not be able to cognitively able to cope with a long meal time. The hydration one, we have got lots of information on the website as well. We've done a couple of articles on the website around hydration and the importance and how much that can really help someone's cognitive ability and their well-being, and also on delirium. Some really useful video footage and article on the website around delirium, which feeds into what you were saying. But also, interestingly, we do a session for carers about own resilience and well-being, and in that we actually talk about just taking a sip of water, how that can alter, sort of, it can relax you because it helps your brain to trigger your digestive system to move, to be working, and to give that more sense of relaxation. So it's so important in many ways. One of the things that's related to nutrition is a question that we've had come in, and it kind of bridges the gap between the medication, the pharmaceutical medication, and the eating and drinking and so on. And it says, I've heard that curcumin and coconut oil are both good remedies for dementia. Is there any evidence to support this?
So anything that's healthy is a good place to start. But in terms of very specifics as such, the amount of the base chemical compound that you need from curcumin or coconut oil is very, very tiny in the kind of foods that we eat. And for the brain to actually benefit from it, you'll just have to have, well, I'm using infinite in a loose term here, but such massive quantities that will then end up creating more problems than actually that's useful for the brain. So, and none of these have been very consistently proven to be effective in preventing the progression of dementia in human beings. They might have been trialed in animal models in a kind of very simple way, but they haven't really taken off in as far as a human brain goes. And as I said, we need to consume a very significant proportion for us to get to that point where brain will allow these chemical compounds to enter it. Brain is a very tightly secure organ that doesn't really allow a lot of things to go in and out. So we need to be very cautious about what we give to the brain. So I would say that healthy meal is very good. Food that's fresh greens, fresh food produce, less of fat, better protein balance. All of that would be very good. Making sure that the vitamin needs are being taken into account, because folate, vitamin D deficiency, very common in people with dementia. So all of that needs to be taken into account, but I wouldn't go so far as to saying that there's this one specific compound such as curcumin or coconut oil that will solve the problem.
Thank you, Raja. I'm sure that's very helpful to the listener. So we've talked about the importance of non-pharmaceutical medications. We've talked about nutrition. We've talked about sleep, exercise, so the physical and the mental exercise. We've talked a little bit about reminiscence and music. I mean, this really is a whistle-stop tour, isn't it? But, there's lots more on the website around all of these. But also activities and the environment. And I know that we're going to be meeting again for another of these Facebook Lives on Thursday, the 4th of July. And we will be focusing on environments and perhaps changes to the environments that people may need to make in terms of, for example, if the person's physical environment had to change because they needed to move home, maybe in with other family members, or or just a change of sort of because they can't cope with the stairs in the house or whatever. So we'll be looking at that in the future. And I just wanted to flag to listeners that we are going to come back to this environment in terms of what if we have to make changes to moving home. And that will be on Thursday, the 4th of May. We're not going to answer it now either, but I just want to give a nod to a comment made by Patricia about medications and hiding them in yogurts. Patricia, we will put, and I will ask one of our practitioners to reply to that in the chat on here so that you can see that and others can see it afterwards. But we'll cover that afterwards. Otherwise, I think we'll spend quite a bit of time on that. And I know there's plenty more that we'd like to say on this subject at the moment. So I hope that's okay, Patricia. So one of the things that we do know, though, is that not only will the environment and changes to the environment or a positive environment can support a person with dementia, it's actually also really important to be able to support the well-being of a carer. Because one thing that we do know is carer well-being is so important, because the burden being carried is enormous, isn't it?
Yeah, absolutely. And I think it's one of the unfortunate things that happens with dementia is the wider ramification and impact it has on family members, friends, carers, and we would all have to come to terms with the person changing in front of us, and we would always go through this journey of trying to understand and be there and support them. And it takes a lot of emotional stress, to the point that there are some studies that report that amongst family carers, 50% of them would encounter depression as a mental disorder at some point of time during this journey with dementia. And that's why we've always had this golden thread running through our narrative to say that it's always important, not just for the person with dementia to have an assessment, but it's also important for the carers to have, which they're entitled to have a carers assessment. So there is the mental health service or social care who can then try and make sure that the carers are supported and looked after as much as the person with dementia. Because just as the sense of familiarity and confidence that an environment brings in, it's a sense of familiarity and confidence that people, relatives, family members, friends bring into the person with dementia. And that is absolutely crucial, because it's very important for a brain to have that degree of social stimulation, of knowing people, of having those conversations. And therefore, whatever we do to try and improve upon the health, the well-being of the carer would be very crucial to not just the carer, but also the person with dementia.
And as you say, that we can only support a person if our own well-being is supported as well. It's a bit like the analogy, isn't it, of you need to put your own oxygen mask on to be able to support somebody else. There's been quite a lot recently talked about, and rightly so, that relationship dynamics can change quite significantly between the person with dementia and the person that's caring for them. If you were a daughter or a son or a husband or a wife and you become a carer, it can shift the dynamics between that relationship. And I just wondered if you had any thoughts around, you know, these things that we've talked about, which are the primary interventions for somebody with dementia, such as looking after nutrition, sleep, the environment, reminiscence, music, and that those are also really good for the carers. It's not only just as individuals, it's fantastic for a dynamic between the two as well.
Yeah, I think, and I think on that line, I think for carers, it's important to schedule respite time. It it doesn't have to be respite in the sense of a very fixed week away or weekend away, or if that's possible, then that's great. But equally, having a time for themselves at some point of time during the course of the week or course of the day even should be very helpful, because then it helps them to recharge themselves. Because if you were to think about it, you could try and make sure that you could have a conversation with someone with dementia saying, well, you need to have this medication. And then the boundary is very thin in terms of saying, are you saying that as a spouse of someone with dementia? Are you saying that in your kind of an informal carer role that you've taken on? Because someone with dementia might be very, very stubborn in saying, I don't want to take it, if a carer was going to offer it to them. But they might be very amenable if they understood that it was coming from a place of love for them. So so that's why I think it's important for family members who are involved in the care and supporting their loved ones with dementia to understand that they're constantly changing their role between being that family member and being that carer, and therefore having that degree of break during the course of the day, so they are able to feel who they are themselves without any degree of external stress, would be one important thing that will make them feel better, relaxed, and therefore it will have a positive impact on the individual with dementia as well. And that's why I think it's also important to have the carer's assessment, because there may come a point where care will have to be more professionally led, and for the person, the family member, to then take on the role of who they are as they are normally related to the person with dementia. So that is a very important part of the carer's assessment as well.
Thanks, Raja. And hopefully what will be of use to people as well is that we do run an online session that focuses on taking care of yourself as a carer, but also, and the next run of that actually is on Monday, the 13th of March. But also we have a series of what we call Wellness Wednesdays with Dr. Jemima Fitzgerald, our clinical psychologist, which are really useful events to think about ways of looking after yourself as a carer. I know Lynn in the chat here has said that in her area, social services haven't been helpful and that they haven't been able to help the person with dementia or the carer. Lynn, I'm really sorry to hear that that's going on for you in your area, and I know you won't be alone in that, but it's very, very difficult. Do pick up the phone to us if you need to, and we'll see if we can support you in some way to find the information and the support that you need to access. Again, Raja, it's kind of 30 minutes has gone by incredibly quickly, and we seem to be coming to the end already. And so I'm hoping for people, this has been really useful, just a quick whistle-stop tour of some of the pharmacological interventions, but more about the non-pharmacological interventions such as the environment and so on. And I know there's a couple of questions we haven't answered in the chat, but we will have a look at these after the event, and we'll try and put some answers in there for people. So that does bring us to the end of the session. Thank you again, Raja, for joining us. Are there any final words you'd like to add?
I just want to share this quote from Hippocrates, who kind of gets everything attributed to him anyway. So he talks about illness, and he says that you can cure sometimes, you can care often, but you can comfort always. And that's what we're trying to do with people with dementia. The cure as it stands is sadly limited, but what we're trying to focus on is making sure that the person and the carer gets the right degree of care and they're comforted during this very difficult journey, with some professional help from everyone in the society to make it easier for them.
Thank you. I think that's a perfect way to finish it, Raja. And at Dementia Carers Count, we do hope that we can continue to do that care, both for
Absolutely.
carers and the person with dementia. Thank you so much, and we'll see you soon for another session.
Thank you, Sue. Thanks, everyone.
Thank you.